Thank you very much, everyone who's joining this afternoon. A lovely sunny afternoon, at least it is here in Glasgow, so hope it's nice everywhere else, for our donor milk webinar. My name's Judith Simpson. I'm a consultant in Glasgow, and I've been the clinical lead of the of Breast Milk Bank Scotland for the last 20 years. So I've got a fair bit of experience in and around the subject of donor breast milk. Probably most of you in the audience know that the updated framework for practice, BAPM framework for practice on donor milk use, was published at the end of last year. And this webinar is really to complement that document. We've made a very conscious decision to avoid things like evidence, regulation and legislation around the subject, but have gone for a much more practical approach, because in our experience, these are the questions that people are asking on the shop floor. So we've got 5 great speakers. They're going to introduce themselves at the start of each of their talks. And because time is tight, I'm now going to hand over to our first speaker, Gillian Weaver.
So let me start whilst you're doing that, because first of all, I wanted to say thank you to Judy, and I also wanted to thank BAPM for organising this webinar and for giving me the opportunity to talk about the need for consent and how to ensure parents are able to make fully informed decisions. For anyone who doesn't know me, just a very quick background. I have a background both in the operational side of human milk banks and in the management of them, and have worked nationally and internationally in the development of standards and guidelines, and with ministries of health largely in Southeast Asia and Africa and India, and with WHO. But very importantly, with Dr. Natalie Schenker, who I think is listening in, I co-founded the Hearts Milk Bank and the Human Milk Foundation. So if we can move on to the next slide, the best starting point, I always think, for any discussion on donor milk is to be aware that there is a nice clinical guideline. It was published a long time ago in 2010, but it does provide a comprehensive set of recommendations that cover the operational aspects of a human milk bank. What it doesn't include are any recommendations on how donor human milk should be used. The website version was renamed Donor Milk Bank Service Operation when it was updated, and sadly, it's now much more difficult to navigate, I find. I don't know if anyone else finds that. And some of the previously available resources, including one specifically for parents, are hard to locate. But the website link is going to come up next. So you can go and take a look there. And then if you move on to the next slide, happily, a year ago, BAPM published this framework for practice on the use of donor human milk in neonates, with these 5 recommendations. They're too small for you to see, but you don't need to right now, because I just want to say that as a result of recommendation 1, which provides for the wider use of donor milk than has previously been commonly adopted, there are now potentially many more infants for whom donor milk will be considered, and so for whom consent will be required. So the numbers are only going to increase. The next slide, please. And then just to go back to NICE for a moment, the answers to parents and carers questions, and they will have lots of questions when you introduce the topic of donor milk, because many will never have heard of it, won't know anything about milk banks. So the answers to their questions will almost always be found in the guideline if they're questions about the sort of practicalities of donor milk. So this is where donor screening practices and mechanisms for ensuring milk safety are to be found. So if we can go on to the next slide. So second in the list of recommendations in the framework addresses the need for informed consent. And this is the recommendation that parents must provide informed consent for the use of donor human milk. And as part of the consent process, they should be counselled regarding the differences between both donor human milk and preterm formula when compared to mother's own milk, including their benefits, risks, and the ongoing uncertainties. And so this needs to take up a proportion of any discussion about informed consent when gaining consent. Thank you. Can I have the next slide? So taking informed consent isn't always easy or straightforward. You don't need me to tell you that, I'm sure. The ethical question marks that often arise are discussed in these two papers, this one and the next one, if you click again. And the conclusions are that in addition to providing sufficient information on the safety and also the quality assurance procedures, then the discussion with parents should include the risks associated with not using donor human milk, as well as any inherent risks of using it. And given the very high safety record of donor human milk, the risks of not using it in favour of formula usually outweigh those of using it. Of course, it's the responsibility of neonatal unit staff to ensure that the potential for the availability of donor milk to undermine maternal lactation doesn't happen. I'm sure Debbie will talk about this in her talk, and that the inferiority of donor human milk when compared to a mother's own milk is stressed, and the reasons why should be given. So, for example, the reduced immune and anti-infective components that you will always get when milk's been heat treated, the loss of fat that can happen during handling, so reduced calorie intake and fewer of those essential fatty acids, the destruction of heat labile micronutrients. Although with supplementation and later fortification, this isn't usually a problem. And then the non-specific antibodies that you would find in donor milk. So not specific antibodies to the microorganisms and any infections that the family's baby is going to be exposed to. And then lower concentrations of some micronutrients. So there's a whole raft of reasons why donor milk is inferior to a mother's own milk. And then if we move on to the next slide, those are the main things to discuss. So safety and quality assurance. And this largely comes down to, in milk banking, the extensive health screening of donors, the testing of milk both before and after pasteurisation, and then the safe handling, storage and transportation. And those, there may well be questions and need to come into the discussion. The next slide, please. So this is just in a nutshell. This I've taken directly from the NICE guideline, but basically, in a nutshell, donor screening excludes anyone who smokes or vapes or uses nicotine replacement theory, replacement therapy rather than theory, anyone who drinks more than 4 units of alcohol a week or more than 2 units a day, and the use of drugs, and then that there are blood tests done at the time of recruitment, and that these also exclude anyone as a donor who has been told by a healthcare professional that they're at increased risk of CJD. So if we go back to the framework with the next slide, Appendix 3 gives examples of what information should be shared with parents about donor human milk. There are several appendices. That's not very clear. I hope you can see that. And there's around about a page of suggestions. If you can do another couple of clicks, it'll show you this is what Appendix 3 is about, examples of information that should be shared with parents. And then, as you can see, there's a page of suggestions. So these are the suggestions that are there within the appendix. So first of all, being able to answer the questions, what is donor milk and where does it come from? Secondly, what are the choices? What are the feeding choices that are available for families? More, please. Prioritization, making sure that colostrum and mother's own milk are prioritised above anything else. And finally, support for provision of colostrum. When will this happen? So if you go on to the next slide, I'll just give you some quick guide to the sort of answers. We've already talked about donor milk and where does it come from. The choices, of course, are that there could be no enteral feeds. So hold off on enteral feeds until the mother's colostrum is available. So rely on PN. And that's assuming that donor milk is being needed in the first day or so of life. Or another alternative would be to supplement any available colostrum or milk, if it's later on, with donor milk or with formula, usually preterm formula. Or in the absence of any maternal milk, then to solely feed with donor milk or preterm formula. So I think that kind of sums up the alternatives. In answer to prioritisation, this is answered in recommendation 3 of the framework. So namely, the importance of support and help for a mother's lactation. And that's optimal support that needs to be given. And to ensure there's optimal support, then there needs to be the inclusion of appropriate staff training on how best to provide this support. So everybody on the unit needs to have been involved in breastfeeding support and optimal feeding support. So, and the answer to when will this happen? Well, showing mothers how to express within 1 hour of delivery is considered the best time frame, but failing that basically as soon as possible, and wherever possible, always within 6 hours. So going on to the next slide, slide 11, the other recommendations in the appendix are that we should think about when is donor human milk required, why is it required, that it should never replace a mother's own milk, and that the taking of consent and that the milk bank can be contacted for advice, info and needed. So the parental or carer consent. And then that if there are tricky questions and nobody knows the answer, then there's hopefully be somebody at the milk bank that can help. So going on to my next slide. Oh, just to add that both clinical and non-clinical rationales should be included when talking about why to use donor milk. That although obviously the possibility for helping to prevent NEC is hugely important, it isn't the only benefit of donor milk. And overall, when used appropriately, the impact on breastfeeding rates seem to extend to the wider population of babies and mothers, not just the family that are involved in that instance. So carrying on to the next slide, the mechanism for taking informed consent is determined by individual units. So verbal consent, if that's the choice, needs to be documented in the medical notes with the date, the name and the signature of the person who obtained consent. Written consent should also be documented and added to the note. So if it's written consent, that also needs to be documented and the consent can then be added to the notes. Digital versions are also going to be increasingly needed. So a suggested consent form is available there, you can see, for all users of donor milk from the Herts Milk Bank. And this we're happy to share with anyone who wants to take a look. It was created in response to specific requests for a dedicated form, and it's shared with parents in our donor milk information leaflet, which most milk banks will have. So when written consent isn't required for many, I guess, arguably riskier interventions and treatments on the neonatal unit, it does raise questions about the necessity for more than verbal consent, because it does suggest that donor milk is less safe than other potential treatments. And also similar consent, whether it's verbal or written, should also be obtained for the use of formula. And the timing of taking of the risk consent is another important consideration, and the available time for discussions. So I think it's worth mentioning, if we go on to the next slide, that the impact of the use of donor milk includes positive outcomes for parents, especially mothers. And I just wanted to draw everyone's attention to this paper because which is from Professor Amy Brown in Swansea and Dr. Natalie Schenker, the co-founder of Herts and the Human Milk Foundation, who doing a lot of collaborative research and is about to be followed up with publication of more results. But this looks at the effect on maternal mental health and describes 7 themes that were identified in the results from the survey of parents, and is I think worth following up on and taking a look at. And then finally, the NICE guideline, which I've mentioned a lot, if we can go on to the final slide, will be updated in the near future, we all hope. It's the only change since 2010 was the addition of 3 words. If you click, you'll see 3 words have been added in 2018, which was to add including internet and social media. And the guideline is getting out of date. Most milk banks, I think, agree that there's a need for an updated guideline, and we hope that that will come fairly soon in the next year or so. But in the meantime, if anybody is interested in helping to get the guideline updated, please register as a stakeholder and talk to your local milk bank, because there are lots of things that can be done to improve the nutritional quality, other quality assurance aspects of milk banking, and lots of other things as well. And in order to respond to the growing demand for milk, I think there's a lot that could be addressed in the guideline. So thank you. I can hand over now to my colleague Amina, who is going to talk about some other very important aspects of donor milk, donor recruitment.
So just to introduce myself, my name's Amina Hatia, and thank you so much for the invitation to speak about milk kinship. As I said, my name's Amina Hatia, and I'm a research midwife with Imperial College London, and I'm based at the Human Milk Foundation. One of the areas in exploring cultural consideration related to the use of donor human milk I've been focusing on is how the Muslim community in particular view and access donor human milk due to the unique Islamic rulings around the term milk kinship, and that's what I will be exploring with you today. So just to kind of give you a brief overview of what I will be covering, I'll be talking a little bit about defining milk kinship, what it means within kind of Islamic religious context, fatwas, which are essentially rulings on donor human milk, and how that relates to milk kinship, research that I have been involved in, and information leaflets that we are aiming to develop, and the next steps kind of going forward from there. So I'm going to start off with this screen, which I hope you can all see. Our research and information development about milk kinship and how this affects the Muslim community in the UK, I think is captured perfectly in this post, which was on a closed Facebook group of British Muslim mothers. I think there is about 75,000 Muslim women who are on that group at the moment. What the post kind of explains is the complexity of what kinship can mean to people, who it can affect, who it relates to, and also the impact donor human milk and its usage can have on families that have had it. It also highlights how we can ensure as healthcare professionals, as people working in milk bank, working in research, that we can support all communities with information that is easily accessible for them to make an evidence-based informed choice, which Gillian has just spoken about. So I'm going to start off by just having sort of trying to define what milk kinship is. It's very much the term milk kinship is a modern kind of Western anglicized term. It's not used widely within the Muslim community at all unless somebody has kind of previous experience of it. So by talking about milk kinship, people might not necessarily understand what you're referring to. It's actually quite hard to be able to define the kind of relationship that is built within kind of the Islamic context through milk sharing. In the Quran, it's referred to as rida or rada, but that kind of speaks more about wet nursing and sharing of milk rather than the kinship. But again, that's not a term that is widely used or understood by the kind of global Muslim population, many of whom for Arabic, which is the language of the Quran, is not their native language, and it's not a language that they use daily or even understand in translation. A term that people might have come across more is the term mahram, which refers to people with whom you have familial bonds that you can't enter into marriage with. So it's not specifically to do with milk sharing, but it refers to people like your brother, your father, etc., that who you would never enter into marriage with. On a practical level, in daily life, Muslim women and Muslim families will tend to use it to refer to as that person is my mahram, or if I was a Muslim woman who observed the hijab, I would kind of say, oh, I don't need to wear the hijab in front of that person because they are my mahram. And so it's kind of more widely used in lots of different ways within the Muslim community and can be used when referring to milk kinship. Within Islam, kinship ties are forged through only three means: through birth, marriage, and milk. So things like adoption, in the legal sense, don't forge Islamic familial bonds. Rulings and beliefs about milk kinship are based on the prevalence of wet nursing, which has actually been practiced widely in Muslim communities and was practiced widely in Arab communities before the advent of Islam for both religious and strategic purposes. A little bit like the practice of godparenting in Christianity, milk kinship was there established to have that second family who can take responsibility for a child whose biological parents weren't able to do so. Now, in relation to donor human milk, the flowchart on the screen illustrates how kinship would be established with the use of donor milk. So the recipient, the breastfeeding mother, becomes the recipient child's milk mother, her children, the children's milk siblings, the breastfeeding mother's partner, the child's milk father, etc. And those milk siblings would be the people that would be prohibited in marriage. And that's where the concern for people in the Muslim community come from. How many milk siblings will my child end up with, and how will I know that that's their milk siblings? Oops, sorry, I've just jumped ahead there. It's also really important to remember that milk kinship is both practiced historically and currently for a whole variety of reasons. Hi.
So we can't see your screen, we just see you at the moment. I think you need to reshare your screen.
Oops.
I can see the screen.
I can see it.
I can see it.
I can see it.
I can see it.
Okay.
I can see.
You can still see it?
Not me,
Yep.
but I'll
Yes.
figure out.
Yes, I think everybody else can.
Yeah, we can see.
Okay, so it's also important to remember that milk kinship, like I say, is practiced both historically and currently for a whole variety of reasons. And some of them I've got on the screen there just for people to be aware. So it's considered an act of sunnah, which is something that is considered a really kind of great act of service. It's a great act of charity, which is the term sadaqah it's referred to. It's also used for family reasons, shared between sisters so that their children become siblings. And if in that family they observe hijab, those siblings of opposite genders would not need to cover in front of each other, and also for reasons of adoption. So adoptive mothers, some Muslim adoptive mothers may induce lactation to be able to feed their adopted child, to create that kinship, or ask a family member such as a sister or a sister-in-law to do so as well. Islamic rulings about beliefs about donor human milk are also explicitly stated in the Quran in the verse that you can see there, which is on a chapter regarding women and covers kind of issues related to family law. This is the main rationale behind the thinking of rulings related to milk kinship. The area that's been highlighted in red refers to wet nursing, the sharing of breast milk, and kind of extends beyond daughters and mothers, etc. as well, that anybody who shared milk will build that milk kinship and that impermissibility of marriage. Rulings, any kind of rulings will depend upon the sect people follow and which school of religious theology they also practice, which can vary. So it's kind of taking into account that in the UK we have a wide kind of heritage of heritages that people come from who follow the Muslim faith. And although milk kinship is referenced in religious texts, its interpretation depends on the family's origin and the culture that they come from. And like I say, within Islam, there exists a whole range of cultural beliefs and religious interpretations, with kind of, like other faiths, lots of different strands. Of 3.9 Muslims in the UK, which is about 6.5% of the population, 75% of the British Muslims will follow the Sunni sect, with 10% following the Shia sect. And approximately around 67% of the Sunni population comes from a South Asian heritage, mainly from Pakistan, Bangladesh, and India. And of those, they will predominantly follow a particular school of thought referred to as a Hanafi school of theology. Now, this is different compared to the USA, which has a larger Arab heritage population, or France, for example, which has a larger North African heritage Muslim communication community, and will follow maybe a different school of thought. Since 2016, human milk banks in Muslim countries have existed. However, each have navigated the rulings regarding milk kinship differently, and there isn't a wide consensus on how a human milk bank can be run in a Muslim majority country or for Muslims. It's also really important to remember how human milk banks operate in a Muslim majority country won't necessarily apply to the UK, and rulings for them aren't often accepted by Muslim families because of that kind of which school of theology you follow. So, for example, in Iran, which follows the majority population follows Shia Islam, the Iranian scholars approved the use of donor human milk because the baby, and there is no kinship issue because the baby is fed directly from the breast. In Singapore, the Religious Council issued a fatwa saying that it was permissible when medically indicated. In Malaysia, the donor and recipient family consent to disclosure of identity, and the same applies kind of in Kuwait as well. Now, the European Council for Fatwa and Research actually issued a ruling in 2004 regarding human milk banks and milk kinship, which is more applicable to Europe and the UK. This fatwa stated that there should be no barrier in Islam to the establishment of the use of human milk banks because there was no kinship issue due to the baby not being in close contact with the donor mother or suckled at the breast, and that they also said that some schools of Islamic thought felt that there was a minimum requirement of 5 complete feeds. Great. However, Mufti Zubair Butt, it's a jumpy screen. However, Mufti Zubair Butt from the Institute of Islamic Jurisprudence in Bradford, when provided with this ruling by consultant paediatrician Thomas Williams, advised that the fatwa would not apply to the UK due to the 3 main factors that are on the screen. Now, whilst his Mufti Butt's ruling are much more limited, they do highlight that any fatwas or ruling must be tailored to the needs of the local Muslim population, and that rulings on the use of donor human milk in Muslim majority countries won't always be acceptable to Muslims living in the UK, for example. Mufti Butt was also the Islamic medical advisor to the Muslim Council of Britain and part of the roundtable discussion with BAPM and the UK Association of Milk Bank in 2015 in London that led to the resolution that concerns about milk kinship shouldn't lead to donor human milk being withheld from babies because there were safeguards in place for the traceability of that milk if needed. And it's this ruling that we focused on when researching creating our leaflet on milk kinship. So going right back to that first slide of the kind of recipient case study who I was in contact with, it kind of captures the complexity of support and questions that recipients and donors may have. We found that families and donors really struggled to understand what the rulings on the use of donor human milk were and were unsure who could guide them. When after kind of discussing this with this particular case study, the recipient mother and family were absolutely aware of the resolution by the MCB and BAPM and UCAM, had read the resolution, had thought over it, but actually didn't feel that they had confidence in the traceability, as it wasn't clear how that would work and what steps they would need to take. They were also weren't aware that their baby would have been given donor human milk from different donors, because we say milk is not pooled in the UK. She felt that milk was going to come from maybe just one donor rather than different donors as well. That milk kinship hadn't been discussed with her before. She felt quite strongly that if resolutions already existed and this information was already out there, how come nobody had talked to her about milk kinship, particularly when she felt that people knew that she was a practicing Muslim woman, and that should have kind of been brought up with her. On reflection, when we reflected about it, the questions that we came up with were, should we be asking questions about religious and cultural reasons for everyone, not just Muslim families, for everyone that may be involved in donor human milk? Because when Gillian was talking about consent, I think that's a really important consideration. Is there something that we should be aware of? Can we help address that or, support you with that? That our parents clearly aware that from the onset that milk will come from different donors, depending on how much milk their donor human milk their baby needs. Should parents be advised how to collect and retain details for traceability? Do they know to retain information, ask for that information, and to kind of retain it themselves? And who do recipients, donors, or anybody kind of interested in this contact if they want to trace donor human milk in the future? Kind of people wanted to know that there was a place that they will be able to go to be able to kind of access that. We also found that milk kinship in relation to donor human milk wasn't particularly well understood by all professionals from all different angles. Imams and jurists didn't understand what donor human milk necessarily was and why it was being used, and they're often local imams are being asked questions by people to make decisions on this. Healthcare professionals were either unaware of milk kinship or had limited knowledge and didn't feel it was something that they could delve into. We also found that Muslim healthcare professionals that we spoke to, particularly those working in neonatal units, found that they were being asked about the permissibility of donor human milk, even if they weren't the clinician leading in care, that people kind of coming to them saying, should my baby take this? Is it allowed within Islam? What would you do, etc. So there's a lot of kind of questioning going on behind the scenes that we might not be aware of. And this led to the creation of information about donor human milk and traceability in the UK. We've started off with a draft leaflet for recipient families, as that's where we felt the need was the greatest, with the kind of people needing to have the kind of relevant information to make it an often time critical decision. And it was designed as an insert to accompany leaflets that neonatal units could use, are already using, or human milk banks are using, and therefore focus particularly on donor human milk and traceability for Muslim families. Alongside a final version of the leaflet after review, we also aim to develop hopefully further information resources focused on milk kinship and donor human milk use in the UK by creating bespoke online and accessible training for healthcare professionals and for imams. Gillian, who just spoke earlier, and Dr. Natalie Schenker and myself are attending a seminar on Islam and bioethics to explore this in more detail. So we're hoping to kind of get the information out there. And then we aim to embed on the Human Milk Foundation website a milk kinship information portal. I say that thinking I know what it means, but something where it contains all of the information highlighted on the screen for ease of access. That's me all done. Sorry if I've run over a little bit. I'm going to pass on to Debbie, and I'm going to stop sharing my screen. Thank you.
So my name is Debbie Barnett. I am coordinator of Milkbank Scotland. I've worked with Dr. Simpson since I came into post actually in 2009. Seems like a very long time ago. So again, I've got quite a long kind of history in milk banking. Milkbank Scotland started off as a very small little milk bank in a cubicle at the old York Hill Children's Hospital, and now we're probably one of the larger milk banks in the UK, providing milk for the whole of Scotland. So I'm going to talk a little bit about using donor milk to support lactation on the postnatal wards. So this really came about because in 2017, the Scottish Government did a maternal and infant nutrition survey, and it threw up quite a lot of interesting data around early supplementation in particular. So 67% of mothers experienced problems while breastfeeding or expressing milk still in hospital, so they hadn't even got home yet. And of them, 52% had difficulty getting the baby to attach. There were another 44 who had concerns around milk supply. And of the 86% who stopped feeding early, that was the biggest concern was milk supply and attachment issues. And 75% of the people who responded to the survey had already stopped giving breast milk and would have liked to have fed for much longer. And that's something, again, that's been, I think, covered in lots of different studies. Amy Brown, I think, has done a number of pieces around that. So, and I think the other things that were quite concerning was that 2/3 of the respondents who had given breast milk also reported that they had given their baby some formula milk, and that a third said they had given formula milk while they were still in hospital or within the first 48 hours of their baby being at home. So that kind of threw up lots of questions, some of which I think were around why were women feeling the need to supplement their babies so early, and a lot of those were out with kind of clinical needs. What was the lactation support like that women, again, weren't getting good advice, and again felt the need to have such an early supplementation. So again, it kind of points to women not understanding early newborn behaviour and feeding within the first few days, few weeks, and questions around lactation support. I think were really the big ones for us. So we kind of had a hunch that the use of donor human milk as an alternative supplement might, and it was a very big might, decrease attrition at 10 to 14 days. And that fits also very comfortably with Scottish Government's stretch aim, which is to decrease attrition at 6 to 8 weeks. So we wanted to test that theory out. So in 2020, we started a little pilot study in the 2 postnatal wards at the Queen Elizabeth Hospital in Glasgow, where the milk bank is based. And we had just over 200 infants received supplements with donor milk. And I think, again, what it threw up was some interesting kind of pieces. So 85% of the women who chose to use donor milk were first-time mums. Very high cesarean section rate. 50% of the women had some kind had a cesarean section, but a further 22% had some kind of instrumental delivery. 16% had a significant blood loss of more than a litre. And babies were anywhere between 34 to 42 weeks. So we don't have a transitional care unit within the Queen Elizabeth at Glasgow, but we do have a ward where I would say some of those late preterm babies will go for care if they don't need to be within the neonatal unit. And again, the weight reflects that from kind of anywhere around 1,750 grams up to over 4.6 kilos. And some of the clinical reasons for supplementation were around those kind of as early term or late preterm babies. Some of the babies had hypoglycemia. We had a few babies with weight loss, but I would say predominantly they were lots of mums who just felt that they needed to have a feeding supplement for their baby for whatever reason. So there were some clinical need, but lots of just maternal requests. So that kind of 3 o'clock in the morning where the baby's just not settling and mum was at the end of her tether. And we saw quite a lot of that. What did we learn? Well, we learned a lot. We learned that we had lots of mums with delayed lactation. Day 4 and beyond, we were seeing mums who really were often, it was day 4, day 5, even sometimes day 6, day 7, where they were still just working on their milk supply. So that was very common. So I think there are lots of factors that influence that. We have a changing demographic. I think we have a huge cesarean section and instrumental delivery rate. We have a lot of inductions. I think there's lots of factors that are influencing that delayed lactation. I think it's also really key that where we are using donor human milk as a supplement, that we need to have two things in place. We need to have skilled staff who are able to provide lactation support, that are able to do some kind of expressing assessment or breastfeeding assessment, and are able to put in a really robust feeding plan, which the mother needs to adhere to. There is absolutely no point in providing donor human milk if the mother isn't adhering to the plan. So we need to have a really clear conversation about, here's the plan, you need to uphold your side of the bargain, because what we don't want is the use of donor human milk just to become a placebo, which I think there's always a danger of. Staff training was key. It's really important with any kind of change that staff are very clear about what you're asking of them. They're very clear about the process for both using donor milk, recording the use of donor milk, and around lactation support, and also exit strategy. So again, what we were looking for was the use of donor human milk to be a very short term, whilst the mother was implementing her feeding plan and working on her lactation. The other thing in conjunction with that was lots of work around helping families to understand newborn care, newborn behaviour, so early feeding cues, how small a baby's tummy is. So we really tried to encourage the use of donor milk in really small amounts. That was a real struggle. What we found was that the mother was often handed a bottle of milk. Our milk contains 30 mils, and the baby would get a 30 ml top up. So moving forward from that, really encouraging the use of donor milk in much smaller amounts. We also have continued some short-term use of donor milk at home, particularly where we're seeing that delayed lactation and where the mother really is adhering to the plan, the feeding plan. So where she is expressing, she is putting the baby to breast, she's doing all the right things, but potentially we're just seeing a little bit of a delayed lactation. So we're comfortable with supporting those mothers with some extra milk for at home for a couple of days, if necessary. Exit strategy is always key, though. We can't continue to provide donor milk ongoing. That's not the purpose of it. And so I think we have to be very clear about this as a short-term intervention, and that it's not always a fix for everybody. There are some mothers where, unfortunately, it just won't happen, and we can't do anything about that, and we don't have the resource to provide donor milk for the longer term. Lactation support I've mentioned already, that really is key, and I think it's still such a big challenge to ensure that families are having the kind of support that they need. My daughter had a baby just very recently. In fact, that little baby in that picture is Clara, who ended up actually being admitted to one of the neonatal units in Glasgow for a couple of days. And I think what's very clear is where there is really good lactation support, even with a challenging beginning, there are ways to support mothers to ensure that they can follow the plan and do skin to skin and really work on their lactation. So I see Judith's just popped up. I'm talking too much as usual. So these are just some of the tools that we developed to really support staff with the implementation. Flow charts, process charts, and the like, just really to try and make sure that staff were engaged and that they could look at something and follow that process. What we saw was a 7% increase in exclusive breastfeeding rates at 6 to 8 weeks. It's not a huge probably not that significant, but actually when you look at the wider context and the work that's going on across Scotland, I think there is the potential to develop this into a wider programme, and that's something that we are doing. We're testing it in other health boards. In NHS Fife at the moment we have a similar project going on, a quality improvement project. I think there's lots of things that we can do. We've got massive amounts of data that we really should be interrogating, probably a bit more than we do. It's always a challenge because of staffing. And I think there's a bit around actually what is the capacity and capability of milk banks across the UK to provide this kind of support, working in collaboration with UCAM, and as always, further research is required. So I think next is Laura and Nick, who are going to talk about Memory Milk Gift.
So my name's Laura Atherton, and I am talking today about lactation choices after loss and the Memory Milk Gift Initiative. I'm the operational manager at the Milk Bank at Chester, and I'm the bereavement lead for the National Memory Milk Gift Initiative. I was going to start off today with a video from Holly, but I am conscious that we're running a little bit behind. So what I will do is I will post the link in the chat at the end of this presentation, and I really encourage everyone to, if you haven't seen the video already, to have a watch of the video, because I think the parent voice is really incredibly important. So the Memory Milk Gift Initiative, in 2021, 13 babies per day were stillborn or died in the first 28 days of life. We launched the Memory Milk Gift Initiative in October 2021 here in Chester, and it was an initiative designed and implemented after we met Holly, the mum that I've just spoken about, who donated milk after her son Bodhi was stillborn. And we recognised a real UK-wide patient unmet need to discuss lactation choices after loss with families. We're supported by the Memory Milk Gift Advisory Panel. You can find out more about them on our website, and Nick Embleton is part of that panel along with Debbie. And we're guided primarily by feedback from parents and the parent voice, but also healthcare professionals across the UK. So this is the link that I will pop in the chat for you to be able to watch Holly's story if we don't have time to watch it at the end. So what are the key aims of the Memory Milk Gift Initiative? So it's to raise awareness of lactation choices available to families, but really importantly, it's to empower healthcare professionals to ensure that every family are offered choices around lactation, which in turn then leads to supporting families with informed choice. We were lucky enough to be part of the BAPN working group for the lactation and loss framework. And there are kind of 4 key choices for families when it comes to lactation management. So there's stopping your body producing milk, so either medical or natural suppression, the initiation of lactation following the death of a baby, or where lactation is established, continuing to express milk. And then deciding what to do with either the milk that you're intending to express or milk that you may have already expressed, for example, if your baby's receiving care on NICU. Something that I'm really passionate about is the understanding that milk donation is not the right choice for everybody. However, it is still imperative that we offer these choices. The role of the milk bank is to facilitate the process if a family chooses to donate milk. And the role of the healthcare professional, as I just mentioned, is to empower those families to make an informed choice. And something that we've had fed back time and time again, sorry, I don't know why that's popped up, is that families can only know the information that we give them. And what we hear from families who weren't offered these choices is that even if they don't know what decision they would have made, there is that feeling of regret and anger if they haven't been offered all the choices available to them. As you can imagine, there were lots of barriers when we first started talking about this. We surveyed lots and lots of healthcare professionals across the UK about what those barriers were. And the main was that we really needed to introduce a standardised approach from UK milk banks. Working collaboratively is really important, and almost every milk bank in the UK is now signed up to the Memory Milk Gift Initiative. We always suggest that families donate where possible to their most local milk bank. That seems to be really important to the families that we support. They really want their milk to go back into the area that they've received the care from. But where that's not possible, then Chester will support anywhere in the UK. Information was really difficult to find for families and healthcare professionals, especially kind of outside of standard office milk bank hours. And so we created a dedicated section on our website for donation after loss, and we produce leaflets that we can turn around into any language within 48 hours. A lot of healthcare professionals were really worried that they may offer the option of milk donation to a family, only for them to be contraindicated. And we talked about some of those contraindications earlier in Gillian's talk. And so when we were breaking down the barriers, we introduced a research donation opportunity, and that has been really well received by families who have wanted to donate. With the support of NAB, the National Association of Blood Banks, we can ensure that there are easy milk collections from both neonatal units, maternity, hospices and home addresses, which takes some of the stress away from the parents. Again, we know that families can find it difficult to repeat their story, and that communication with GP practices aren't always as smooth as they should be. So we provide neonatal units with blood collection kits, as well as maternity teams as well, so that bloods can be taken if required for before the family leaves the unit. And we've removed minimum donation amounts. Now, when I say we've removed them completely, if a family wants to donate for recipient purposes, then we do require 200 ml of milk. That's so that we can microbiology test the milk and ensure that we're adhering to those NICE guidelines. But for research, there is no minimum donation amount. So the progress that we've seen over the last 2.5 years has been incredible. Milk donation after loss isn't a new concept. Many milk banks have supported families to donate after loss, but because there wasn't very much awareness and very little education and accessibility to information, many parents weren't offered that choice. For example, here at Chester, on average, we supported approximately 12 families per year prior to the launch of the Memory Milk Gift Initiative, and they were all families from NICUs who had express milk prior to their baby passing away. What we have seen is a 5-fold increase of families donating milk to the Milk Bank at Chester, and in less than 3 years, we've actually supported over 170 families to donate milk to Chester. Other UK milk banks also report an increase in supporting bereaved families, and I know that we also have Memory Milk Gift Scotland that Debbie oversees in Glasgow. So what we can really see here is that by offering choices to families, there is a huge increase in uptake. What we want to really be sure about is that, you know, there is equitable access to donation, because we don't want to be adding to that regret where a family in one area may be able to donate milk, but in another area they may be unable to. And what you can see from our donor demographic slide here is that actually we are really reaching a huge range of families. So from a location point, religion, sexual orientation and ethnic origin, we are improving the access to donation for families across the UK. So what are the next steps? Well, we need to really raise awareness and make sure that this information is accessible to all families. And mainly, we need to ensure that all healthcare professionals can access both the information and education. And that leads to a reduced regret and trauma further down the grieving process for our families. So, Nick, if you want to jump in at any point with this, we are really pleased to be able to announce that we are launching an online educational tool for healthcare professionals. So it's a Future Learn course, and it's co-developed with the parent and family voice at the centre of the course. We have engaged with several families to make sure that we can really support that, really make sure that the course is centred with the parent voice at the heart of it, so that we can learn from families and experience. It's set to launch in June 2024. It'll shortly be going out for review and endorsement, and it's heavily based upon the BAPM framework for lactation and loss. We are really grateful to the Tiny Lives Trust, who funded this platform, and we're delighted to be able to say that there will be free access to all NHS staff. So this will be a really useful learning tool for healthcare professionals across the primary care setting, and also maternity, neonatal and hospice staff as well. So I am pleased to be able to show you a few screenshots. The link isn't live yet, but as soon as it is, we'll be able to share that. So please do let us know if you're interested in learning more about this. As you can see, it's for anyone that's seen the BAPM course, the framework, sorry, we talk through the physiology of lactation, we talk about lactation suppression, considering different views, and there's also quizzes at the end of each week's session so that you can test your knowledge. We have videos, so this is Holly, so this is the video that I will share with you as well. And here are just some more slides, but we also have audio clips from families who weren't offered the choice to donate as well. So if anyone would like to know more or has any questions, then please do ask or pop them in the chat, and then I think Sarah and Judith are going to lead the questions shortly. I think I've managed to pull that together, so we're back on time for question time. But I will put the link for Holly's video in the chat because I really would advise that you take the time to watch that video.
Thank you, Laura, and I completely agree. Anyone who hasn't seen that video should watch it. It's incredibly powerful, and 10 out of 10 to Laura for her timekeeping, but everybody's talks were brilliant. So I'm handing over to Sarah to coordinate the questions and answers. There's been some questions in the chat, some of which we've answered along the way, but I'll step back a little bit, Sarah, and let you lead on this.
Lovely. Thank you. Firstly, just to thank all our speakers. Number one, for pulling it in on time, but also for some fantastic presentation. It's been great to have the different angle around donor breast milk, because we do churn out quite a lot of the same stuff. So about when we should use it, why we should use it, but actually thinking about it from these different angles has been really stimulating. And we've had lots of questions already in the chat. Is there anyone who would like to raise their hand and ask a question of our speakers live? Nick?
I wasn't going to ask a question specifically, but just to kind of refer to some of the discussion in the chat and some of the points that Debbie was picking up on. Probably the 100 people signed into this webinar are all very in favour of donor milk. I think all of us know that we haven't convinced all of the neonatal community that this is the optimal nutrition for every baby, premature baby. And I think that's because we never managed to get together and do the conclusive trial to show the benefits of donor milk in the smallest babies. And now most of us lack the equipoise to do a trial using formula in a 24-weeker. I simply wouldn't do it. But when we're thinking about some of these larger babies, the babies on postnatal wards, the cardiac babies, the surgical babies, I think there is a really important question there. And I would encourage people who are interested to try and get together and design a really good RCT. Because without a good RCT, you will not get it funded. And we can see at the minute with donor milk, it's not funded, right? Individual units who have a milk bank can access it for their own babies. We haven't got a milk bank, so we don't have that luxury. So if all of us want to make the case for donor milk, we have to do really good RCTs. It doesn't help to say, well, my opinion is that it's really good for these babies. You might be right, but without an RCT, the NHS will not fund it. So if we want to see donor milk being used in these other babies, used on postnatal wards, we need to get together soon and do good trials, because that's the only way you will get it funded.
No, I totally agree, Nick, and I think that that is the issue that we're now in with our preterm infants, isn't it? That we don't have that convincing evidence or good enough evidence to promote the use of milk and also promote the funding of it. There's a couple of questions in the chat. One, just to pick up on that, is around supply. So Debbie, this might be one for you. From a point of view of alongside funding, is there enough supply of donor milk? So someone, I think from Southampton, popped in the chat earlier around the use of donor milk in their unit, which is on a traffic light system. So if they have enough, then it's open to everyone. If they don't, the supply is a bit lower, then they restrict use. And I think there's something around equity of access, and that was really heavily promoted within the GIRF report about equity of access. So I think that's what's very difficult with this type of product, because it clearly is on a supply. It can be a supply shortage. So one of the things that's holding a lot of units back is around, actually, if we're going to use it, we've got to offer it to, we've got to have it. We can't have it on a sort of piecemeal basis. So supply is really important. So maybe Laura and Debbie can answer that.
I'll go first. So I think again, not all milk banks are equal, is the other thing I would add to that.
Mm.
So Laura would probably, and I would imagine that Hearts are probably going to echo kind of what I'm about to say, which is we are fairly consistent in our supply. And so we're able to manage most of the requests we get for use of milk within postnatal ward. It is also about funding and about how milk banking is not equitable across the UK. So in Scotland, we have a very different funding model because all of the health boards contribute a percentage of the running costs. So that makes it a much more equitable process than it is across the rest of the UK. So there's no limit on supply in terms of cost. And to date, apart from a very few occasions, we've always managed to have sufficient supplies. Interestingly, we're slightly lower than we've been for a little while, but I think that's in part because the use within our neonatal units has increased, and we are seeing a different demographic. We are seeing more term babies receiving donor milk, but actually those are babies who are in the neonatal unit, not within the postnatal wards. So I think there's lots of things that need to be unpicked. It's not just about use within the postnatal wards, it's also about the use within that wider demographic of babies within the neonatal setting who are term babies but are being admitted with other challenges.
Mm-hmm.
So I think it's not an easy question to answer. Yes, we have enough milk, but as Gillian said right at the beginning, the demand for milk is growing. Rightly or wrongly, it is growing.
Yeah, I think, sorry, Sarah, I think we echo that at Chester. So we're funded totally different to Scotland. The neonatal units purchase the donor milk. We're a not-for-profit service. So we charge them the cost of processing the milk. We had a quite severe shortage about 2 years ago now. We didn't restrict our milk. We reached out to the other milk banks across the UK, and what we've done since then is really work a network, especially in the north. So we work really closely with Calderdale Milk Bank and Birmingham Milk Bank to support. The best thing that we did was really engage with our neonatal units, because what we find is that a lot of the mums, as they're establishing their supply, do have a surplus of milk. So by working more closely with the neonatal units, raising awareness of donor milk and donation as well, because a lot of families don't think to donate. So it's about having those conversations when they've got a poorly baby. That's not the kind of first thing on their mind, but working with the neonatal networks has really increased our supply, and we are seeing an increase in demand for donor milk, but we're also seeing a huge increase in donors as well. So I would say that as we raise more awareness and as we work more collectively as a network of milk banks, that we are managing that supply much better.
Thank you. Judith, do you want to come in on that?
Don't be annoyed with me, Debbie, but Debbie is aware that I feel that we do need to manage the potential tsunami of demand if we're supplementing term babies right, left and centre. I'm sure everybody's the same. The demographic of our mothers is changing. We have more diabetic mums. We have more that are having planned caesarean births. We're having more that find it challenging to get lactation established. And I do agree with Nick. I think that the sort of role of supplementation with donor milk as opposed to formula in the term infant or late preterm infant, with an outcome that looks at establishing breastfeeding at one of the COT time points after these families go home, would lend itself well to thorough interrogation with an RCT, not a quality improvement exercise. It's appealing, but it's inequitable at the moment, and we also run the risk, whilst we are lucky in the way we're funded, we are not a bottomless pit of donor milk, so we need to make sure that we use it in an evidenced and best practice way. So I really feel quite strongly that this group, we need to get good evidence, because they will consume very large volumes of donor milk. And also, if it works, it needs to be available to everybody, not just those within the catchment area of a milk bank that happens to be well funded.
Absolutely. Gillian, can I bring you in? You're next.
Yes, thank you. And I couldn't agree more with Judith and Nick. Absolutely, we need an RCT. One of the big questions that gets asked is, where would all this milk come from? And I just wanted to tie it into my appeal about the NICE guideline, because the NICE guideline never stated who the milk was for. And so the assumption always had to be that the recipients would be the very tiniest, very sickest babies. So the constraints that we have in terms of donor recruitment and in terms of the testing of the milk mean that we turn away a lot of donors, potential donors. We have to discard a lot of milk because it doesn't meet what I will have to describe as very spurious microbiological criteria. And that if we could address this, at Hearts we have a two-pronged approach, so that donors, we have a community programme, and women who can't donate for hospital use milk can often donate for use in the community. So there are medications that are excluded for donation to hospitals that have been deemed safe by UK DILAS and other experts for term babies and so on. So I just wanted to raise that providing donor milk both to bigger babies on the neonatal unit, to postnatal babies and to babies at home doesn't have to detract from the volumes of milk that are available for preterms and for very sick tiny babies. And in fact, there would be better use of all the equipment and the staffing and so on if we could have this approach.
Fantastic. Thanks, Gillian. Nick.
Yeah, just to pick up on those points. I already said I think we do need an RCT in these babies before we end up in a situation of not being able to do an RCT. I mean, once it creeps out there and everybody says, well, this is the standard of care, it becomes very difficult then to do your RCT. And there will be supply issues. We know from our own studies that one or two, what we call super users of donor milk, the bigger babies where the mums really are very reluctant to go onto formula milk, use 10 times as much as the 500 grammers with the poor mums who can't express anything. And when we've been trying to do a pilot trial in the postnatal wards here, just picking up on what Natalie says, we actually found lots of mums who would not join our trial of donor milk versus formula, partly because, as Natalie says, most of the public don't understand that donor milk even exists as an entity. What happens on the NICU is that the parents are so scared and overwhelmed that the nurses say, "Oh, you're happy for your baby to have donor milk? This is what we give," that all the parents consent to it. But for the mums on the postnatal wards who have babies at risk of hypoglycemia who've never heard of donor milk, about half the babies that we try and recruit won't join the trial because they don't like the idea of donor milk being given. So as I say, I think there's amazing opportunity there for people to do really good trials of donor milk in these babies before, as I say, we end up in a situation of babies being born in units which have their own milk bank being allowed to have access to it, and poor babies in the northeast where we never established a milk bank always missing out because we can't purchase it for our tiniest babies.
Yeah, absolutely. Debbie.
Yeah, sorry, just trying to unmute myself. What I just wanted to say a couple of quick things. There is a bit about the volume that these babies take. So actually, what we've been very clear about is that those babies who are receiving donor milk, particularly within the postnatal wards, it's a very short-term intervention. I think we also have to consider lactation support and the kind of work that's going on within our neonatal units. Certainly I can talk about Glasgow and Scotland to really support early lactation and expressing. So the need for longer term donor milk is the thing that should be least problematic. We should have mothers who are getting really good lactation support, and therefore the requirement for donor milk is much less, particularly in those babies where it should be a really short-term intervention. So I think we need to try and not think about it like that, and view it as a potentially more positive thing. I agree totally with what Judith is saying and what Nick is saying and everybody else, that, you know, we do need to have some research to back that up, but I think we need to also be realistic about the volumes that we're talking about. And I think the point that Gillian's made about stratifying milk is really key as well, because there is more volume. And the other point that I think Nick made there was about parents not understanding the benefits of donor milk, but actually I think there's a bigger question, which is parents not understanding about newborn behaviour, about the impact of formula on their baby's gut, the long-term health implications. So it's not just as simple as not understanding about donor milk. We also have to educate around newborn behaviour and the risk of formula. So I think it needs to be a multifaceted approach, rather than it just being an RCT that gives us those answers. It's not that simple.
If only things were that simple. I think since I came into neonatal nutrition, I realised that nothing is simple. Thanks, Debbie. I just wanted to pick up on one of the questions in the chat earlier around information leaflets for donor human milk. And just to flag a project that the neonatal dietitians group are currently working on with Bliss is to actually produce a generic donor milk information leaflet, because everyone was beavering away working on one of their own. So we decided to get together and co-produce a leaflet for parents around the information that they really want to hear about donor milk. So hopefully that project will come to fruition later this year. So we're sort of about a third of the way through that. And another question actually for Amina, which I think is really important. It was one of the questions I wrote down here, that if a Muslim parent asked me if they could get the info on the donor, for multiple moms, to ensure avoiding marrying a kin in future, what should I say? Is this possible in Scotland and England?
Hi, thank you. So it is, because that's what the kind of resolution in the roundtable discussion says, that you should be able to trace the milk back, and if somebody wants to be able to do so. In reality, we know that people really struggle with this, and actually, you know, how information is being shared and being stored varies from milk bank to milk bank. And, you know, what information do you need 20 years from now to be able to go and ask a milk bank that question is the reality of what people kind of, I think, want to know. So, you know, when we're talking to people, what we're advising them to do is holding on to actually being an active participant in that, and saying you retain as much information as you can. So information, you know, obviously things like which hospital your baby is at, where they receive donor human milk, the time period that they receive the donor human milk within, also things like barcodes that we know are traceable, so that if in the future, should that come up, you've actually got a lot of the information there as well. Because I think in the past I think there was an idea that it's in your baby's medical records, and you can go in and look at that and pick it up and call a milk bank and say, can you trace it? But it doesn't work that way. I spoke to a family just yesterday, and they were saying, oh, you know, people keep saying it's in my baby's medical records, and now everyone has access to things like the NHS app, and they're like, I can't see anything on the mum's app on there, and you're going, you know, probably won't be there at all, and that's not actually going to be particularly useful for you. So traceability does exist. It's not a perfect system, but actually the more we can support families and parents in being active participants in that, in retaining as much information themselves, the better that is for them. And I think it also gives them a lot more confidence as well, that actually I've got the information, rather than just blindly trusting that somebody is doing all of this. And, you know, one of the things that we're hoping to do in the leaflet is, you know, what kind of information you need and what questions you might want to ask, you know, about the milk that your baby has received as well.
Fantastic. Yasmin, do you want to come back on that?
Yeah, what I would say, you know, if I say to a mum, yes, traceability is, we offer traceability and this is possible And obviously, if they're Muslim, and we know that they might, maybe most of them won't, if they are going to marry another Muslim. But in those cases where they feel that maybe they would, and then if like 10 years down the line or 20 years down the line, it comes out that this is not possible and we are expecting them to keep a record of everything, which we have not told them at that time, and which I don't think is nice to expect from the parents when their baby is in NICU, that they're keeping a record of all the barcodes and everything. And we say that the hospital couldn't do it, but we were expecting you to do it. And now because of that, we are not able to give you full list of maybe 5 or 6 donors. Then it means what I told them today was not true,
I mean, it won't not be true, because every, all the milk is traceable, and that's where that resolution in NICE guidance has come from, that, every bit of donor human milk used will be traceable, because that's the safeguard that's absolutely there in place. The idea of saying to parents, absolutely it is traceable, so far from the people that I've spoken to, hasn't given them that reassurance. They can't see the journey of how that will be, and it is quite a complex journey of, the first questions you ask are, if you've got a son and he's had donor human milk and he grows up and he meets a girl, and then there's a whole process that you have to go through. Did your mum ever donate any breast milk? Because I was somebody who had donor milk, and they can have, actually, no, my mum never did. That stops that journey immediately there. Yes, my mum did. At what period of time did your mum? Oh, actually, it wasn't when you were having donor milk. That stops the journey there. And then it becomes more and more involved. But it's really hard to map a whole journey out for someone when they're asking for that reassurance. So it will always be traceable, and I'm going to leave Gillian to explain that in more detail, but it will always be traceable. It's the idea of sort of saying to parents is, yeah, it will always be traceable, but also hold on to information yourself as well, because you've got it then. So what you're not doing, and which I work as a midwife in clinical practice as well. What I don't think any neonatal unit wants is anyone ringing them up 20 years later saying, right, I want to know X, Y, and Z. So we're just trying to kind of support people with kind of going, when and where you want to have that, you've got that information is being logged, but you've also got that information as well. So you maybe bypass some of those steps a little bit too.
Thanks, Amina. Are there any other questions from the audience? I just wanted to pick up on one of the questions in the chat to the panel around milk from other family members, because I think that's something that we are asked, and there's some interesting comments in the chat about this happening in other countries, and we always say no in our health service. Certainly where I'm working here in the West Midlands, we would be like, no, but actually is there anyone, I'm interested in the audience, is there anyone out there that's happening in the UK, or is there anything we can do to facilitate that, or do we then just have to refer that family to the milk bank? What are people's thoughts on that?
Can I interject here, Sarah? So when kind of this is an area sort of around kinship. I'm Muslim myself, and it's an area that I've been interested in for a while. And I have definitely seen on some of those Facebook groups people requesting breast milk from somebody to say, my baby is in NICU. This is in England, in London. A couple of times my baby is in NICU, and they've offered my baby donor human milk, but we don't want to use it because of the anonymity. Is there somebody who is willing to support us with that? Because the clinician has said that we can ask if there are family and friends who are willing to do that. It's also a question that, from my experience, Muslim families constantly want to know, why can't that happen? I was speaking to a family just the other day on their experience of it, and they'd, you know, had a baby who'd been born who'd been offered donor human milk, and they had concerns about milk kinship and how many milk siblings their baby would have. The mum's sister had recently had a baby herself and said, I'm willing to donate my milk, and that particular hospital said no, and that was just they couldn't understand why it's their baby and why they would not be able to do that, and why it would have to go through kind of a kind of more formalized process.
So I think there are questions around then around safety. So would that milk need to be pasteurized? Would the donor need to be tested? Who's liable if something happens? Not all neonatal units have the facilities to pasteurize milk. They might not have a milk bank locally to do that. So I think it's something again that needs a lot of discussion. And again, what it also says to me is that it's not necessarily about exploring that avenue. It's about actually ensuring that we have milk banks that are fit for purpose, which means that those of ethnic minorities, Muslim families, Jewish families, other religions have the same equity of access to donor human milk and the same reassurance that everybody else does. I think that is a much better option than going down the route of finding out how we can accommodate in these smaller numbers. It's not the answer. It's much more important to make sure that we have an equitable system in place.
Thanks, Debbie. Laura.
And we've also had this question raised, but in a different area. So where there is a non-birthing parent who has induced lactation, and whether they can feed the baby and whether that can take place on a hospital site, because if it's the birthing parent who's inducing lactation, then they have had their antenatal blood test, they've had screening, there are elements of screening. And so this kind of opens up a huge number of questions for non-birthing parents who induce lactation as well. And I think that it's somewhere that we kind of have no knowledge as a milk bank community of how to advise on that either. So I do think that this will be something that we need to review quite closely in the future. But then again, staffing and milk banking, the funding that's available, can we even begin to go down that route at this stage? And I think probably not as milk banks right now, but I think that's definitely a step forward that we need to take in the future.
Absolutely. Thank you. I'm going to hand back to Judith. We have a couple of minutes left just to close for today.
Yeah, thank you very much, everybody. I hope the comments seem to reflect the fact that I think it's been a great afternoon, really interesting talks, incredibly well delivered, and all kept beautifully to time. Look, we're 2 minutes within time, and Sarah, questions pulled together at the end by Sarah. There's lots of discussion in the chat. There's lots of links to interesting things for people to go away and read about. I hope everybody's found it useful. If there are any other questions, I'm sure all of the speakers here would be happy for you to contact them directly for more information. So thank you very much for joining us. Thank you very much to the speakers. Thank you to BAPM for organising it, and enjoy the rest of the day.